Vaginal Estradiol make fibroids worse? I'm Dr. Valorie Davidson from Progress Your Health.
And I'm Dr. Robert Maki from Progress Your Health. So we have a community that's launching.
Yes.
Actually, the day this episode is going to go out, today, August 11th, 2025. It's our first official community. I'm pretty excited.
I'm very excited. It's called the Progress Your Hormones community as opposed to our Progress Your Health. So a little spin on words.
Still both PYH,
Yes,
either way you
PYH.
slice it. So a little play on words there. So the enrollment, if you're somewhat interested and you're hearing this for the first time, or if you've heard us talk before, the enrollment is going to be open from August 11th until Monday, till Sunday, August 17th. If you're interested, there should be a link down below in the description, progressyourhormones.com. I hope to see you on the inside. It should be lots of fun.
I agree. We're going to create a safe space where women can come together for discussion. We'll have interaction with us because we'll have live office hours, live events. We'll have a hormonal hot seat where we can teach you all about your labs and being able to interpret them. So this has been almost a dream come true, honestly, because I've been wanting to do this. I've been dreaming about this for probably over 15 years. So yeah, it's happening.
It's taken us a while to get here, but it's finally happening. And it was a long process, but I'm very happy with the results and can't wait to connect with people on the inside. So now we have a question today from Cassie. This one came into us again from Ask the Doctor, our little tab on our Progress Your Health website. Why don't you go ahead? This question was submitted to us on June 4th, so we're a little bit behind schedule. Oh. Why don't you go ahead and read Cassie's question?
Okay, so hi, my name is Cassie and I'm 45. I take estradiol for UTI prevention, urinary frequency at night, and found out this week I have 3 coin-sized fibroids. No larger than 1 inch, but my mother and grandmother had severe fibroids, and my mother had her uterus and ovaries removed in her late 40s. My fibroids are not giving me issues, but can estradiol contribute to the growth of fibroids? If so, is there a less estrogen therapy to prevent UTIs? Since I've started vaginal estrogen, I have been UTI-free for 13 months.
Well, congratulations on the 13 months. We try very, very hard for women, our patients, not to use too many antibiotics when it comes to their UTIs. Because what will happen conventionally, you get one, and then you get another one, and then another one, and then pretty soon you're on a merry-go-round of antibiotics. You're getting a UTI every 4 to 6 weeks. It just keeps you, in that vicious cycle, and you're having one UTI after another. So what do you think about her estradiol question?
Well, there's a few things. I think I'd like to talk about her fibroids a little bit. Mm-hmm. So fibroids are really common. A lot of us might even have fibroids and not even know it because, like Cassie's saying, they're not giving her any issues. So that's a good thing. They're not necessarily active, but at the same time, because of her family history, because I do see if grandma had fibroids, mom had fibroids, she's got fibroids, it does run in families. Mm-hmm. So even though they're small, they're no larger than 1 inch, and she's got 3 of them, that's where we want to be really careful at not stimulating them to grow because she has that genetic potential for that.
Yeah. Now, one of our rules that we've had for a very long time, that's why we chose this question, which, it is a very good one. Our rule has never been to use estradiol vaginally. Why has that been our rule for so long?
Now, I know a lot of people have actually written about that. Like, what do you mean? My doctor gives me estradiol all the time vaginally. They say it's safe in small doses and not that frequently. But I still don't like to do it because the uterine lining it's an estrogen sensitive tissue. And in your uterine lining so you have these receptors. You have the estrogen beta receptors and estrogen alpha receptors. Now, there's lots of alpha receptors in the uterus, and that's what estradiol can stimulate. So if you're putting estradiol vaginally, it's going to matriculate up that vaginal vault, the vaginal canal, and it could stimulate those receptors, so the estrogen alpha receptors, and cause thickening of that lining or potentially cause fibroids to be activated or grow.
Yeah, no, she said she's not having any problems right now, so she's obviously probably not having any heavy bleeding or frequent periods or anything like that. But if she continues to use estradiol over time, it certainly could. And maybe she has to be a little bit later in her 40s for those fibroids, as women are, and the ones that are dealing with late stage perimenopause know that their periods tend to get a lot heavier right before they get into what is your new term? You just came up with a new term.
The in-betweeners.
The in-betweeners. So it sounds like mom and grandma, they had hysterectomies when they're in that in-betweener phase.
Where they're going from perimenopause into menopause. So you're not quite in perimenopause because you're not quite in menopause because you're not quite there, but you're just coming out of perimenopause. I call that kind of the in-between stage. And that's really common to have a little bit more estrogen dominance, that progesterone deficiency, but then that estrogen is starting to dive. So a lot of times that's sort of the limbo land of hormones, or, where do you put them on HRT? Do you not? So she could be in that position there. But I would say more so there's probably, like you were saying, her grandmother and her mother had fibroids. There is certainly a potential for those fibroids to grow. And what we want to do is not grow them.
Yeah, right. We want to keep them sort of dormant so they don't cause her any problems, and her cycles don't get worse over the next 3 to 5 years as she's transitioning into menopause. So we don't use estradiol. Almost, I can't even think of a situation where we have used estradiol. So our
You mean vaginally? We use estradiol all the time systemically, but not necessarily vaginally.
Right. That's what I meant. We don't use it vaginally, particularly because of issues like this, the endometrium, and not stimulating growth of anything else. So our little secret weapon has always been to use estriol. Okay, why do you think that there is so much of a push for estradiol and not one for estriol?
Well, in our country, the U.S., the estradiol is just so much easier to get. You can get it at a big box pharmacy. You can get it any doctor prescribe it. Where I know in other countries, Estriol is actually available. I've had some other people, which has been so cool, writing me from other countries saying, "Hey, I can go get this from my local pharmacy. We have Estriol available without a prescription," which I think is so amazing to have that available like that. But I think it's because the estradiol is just easily accessible.
FDA approved, right? Where they're unfortunately, like you just said, in the United States, Estriol is not FDA approved. So you have to go to a compounding pharmacy to get Estriol, where estradiol, there's a variety of different options at the pharmacy to get estradiol.
So just because I like the science, and I hope I'm not boring everybody watching or listening, but like I was saying, in the uterine lining, there's the receptors, the estrogen alpha receptors. So that's what the estradiol is going to stimulate. Now, we don't want to take the estrogen away from Cassie and she gets these UTIs back and she's going to the bathroom all the time, because estrogen is really good for keeping that microbiome of your vaginal vault really balanced. But if you look at the vaginal canal, in the vaginal canal, there's a lot of what they call estrogen beta receptors. Now, beta receptors are on the bladder, they're on the urethra, and they're in the vaginal tissues, but they're not necessarily in the uterine lining. So if she were to use estriol, which is E3, it could still help the vaginal vault microbiome, help the moisture of the vaginal vault, help the lubrication of the vaginal vault. It can help the urethra kind of get a little tighter so the critters don't crawl up and cause that bladder infection.
Or any incontinence.
Yes, exactly, that urinary frequency. So I would say for Cassie, just because of her history and already having 3 fibroids, they're little baby fibroids, they're little baby ones. We want to keep them babies and want to keep them quiet. I would say the estriol, she'd get probably just as effective as she's getting, with the estradiol that she's using, but at the same time, we'd be reducing the risk of aggravating those fibroids.
Yeah. Now, frequency-wise, I don't think she says how often she uses it. So when we use estriol in the beginning, a little bit more frequent.
Vaginally.
Yeah, vaginally, a little bit more frequent. Every day for, what do you usually tell them when they're starting it for the first time? What do you usually tell them to do?
It kind of depends. This is for education only, educational purposes, but it kind of depends. So let's say I'm seeing a woman that's postmenopausal. She hasn't been taking HRT and her vaginal tissues are really dry and she can't have intercourse and it's very painful. I would have them use the estriol, as I use a pretty good dose, and I have them use it every day for like 5 to 7 nights. And then I back it off to about 3 nights a week. And then later, when those tissues get a little bit more of that resiliency and that lubrication and that sensitivity and that plumpness, then we might do it, twice a week to once a week and then kind of balance it out that way. Now for Cassie, she's 45 years old, so she's not postmenopausal, is probably for her, depending on the amount or the frequency she's using her estradiol, is I would probably use that Estriol about the same amount of time. Now, I don't really have a lot of women that need to take it every day. I really don't. I mean, honestly, I'd say out of 20 years of practice with thousands of women, I've never had women use Estriol vaginally every day. Not really.
Yeah.
So I'm hoping she's not applying that estradiol every day. I'm really hoping she's not. But usually at the most, especially for the urinary incontinence, is I might do like maybe 3 nights a week.
Yeah. So usually, excuse me. So usually, what I would tell the patients I've had, they do it every night for 7 nights, every other night for another 7, and then from there, they usually, every woman knows their body pretty well, that they're able to use it, somewhere between 1 to 3 times a week thereafter. That sound about right?
Mm-hmm. No, absolutely. And there's different bases. So when you're getting the estriol, like you said, you can get it from a compounding pharmacy in this country, which is so cool. Is you can do different bases, and I usually they'll do a really nice like hypoallergenic Versa base, which is okay for the vaginal tissues.
Yeah, it doesn't burn or cause any
there's-
irritation or anything.
Because there's different bases that you might use more systemically on transdermally, but that might not, go well with the vaginal tissues just because it's so sensitive, and that you want to use the estriol to help that vaginal vault microbiome, because when estrogen drops, that can cause different critters, that can cause bacterial vaginosis to happen, it can cause yeast infections, so you kind of throw off that microbiome when someone's estrogen starts to drop. But I do think the estriol is really nice, just not for the biome, but also for that urethra, for the bladder, and for the vaginal tissues.
Yeah. Now, compounding pharmacies, again, we've talked about this all the time, but they can also create, instead of a cream, they can also do suppositories, right? So depending on the situation, depending on what you're trying to accomplish, there's lots of ways to apply something like that. But that's been our rule for a long time. Estriol only for vaginal use. We don't use any estradiol on the vaginal tissue for exactly these types of issues. They're both effective. They're both going to keep her UTIs at bay, or if there's any dryness or pain with intercourse or anything like that. But it's going to avoid those other potential issues. So.
And something you had mentioned that I'd love to circle around that may not be completely about Cassie's question is she's 45 years old, which is, that's pretty much like a classic age for perimenopause.
Yeah.
And in perimenopause, that progesterone drops, but you're still sort of cycling, but the estrogen in perimenopause can go up really high, and then it can crash down, and then it can go up, and it can go down. And that's throughout the entire cycle. So that right there can aggravate, because the progesterone's low, that can aggravate those estrogen sensitive tissues. That's why women will get the lumpy cystic breasts when they're in their mid 40s, or the breast tenderness. That's why they get the mood swings. That's why they get the weight gain. That's why the periods get heavier, because that endometrial lining gets thicker and those fibroids can grow.
Yeah, right.
So that would be one thing that Cassie might want to look into, is possibly trying to balance out some of that estrogen dominance and progesterone insufficiency that can happen in perimenopause.
Right. So when women are looking at their lab work, then this is where they want to pay attention. As you see their FSH levels bouncing around, FSH is going up and down. The higher the FSH goes, the more it's yelling at the ovaries to do something, mainly produce estrogen, right? So is that why mom and grandma then had their hysterectomies, probably in their late 40s, because of that surging estrogen levels, right? Which exacerbated the fibroids. The fibroids probably had been there for years and years and years, but that late stage perimenopause and those hormones actually, you would think that if you thought about it, linearly, that your estrogen levels would just kind of gradually just drop right off. But in reality, at the end, they kind of go like this a little bit, and then they drop off.
Yeah, like they can spike and go up and down throughout that cycle, but then overall they're sort of going down.
Yeah.
And then the progesterone's flatlined.
We had like a little whiteboard. So it's like going like this, and it just kind of goes down in intensity and amount, but enough to stimulate those types of hormone sensitive tissues. And now women in they're 47, 48, 49 are getting hysterectomies because they're bleeding like crazy.
That's probably the most common age to get a hysterectomy is in the 40s. Also to get an ablation, which is where that lining's too thick and they're bleeding too much. So they'll take out the lining of the uterus down to the basement membrane. Or that's a lot also when sometimes women end up getting D&Cs because they've had such thickened lining. Now, just for transparency, I've had my own hormonal issues, which is why I love to work with the hormones, but I've had a couple of D&Cs before because when I was younger, I had a very thickened endometrial lining because my uterine lining is very sensitive to estrogen. So I had that, what they call endometrial hyperproliferation. So I've had those before. So it's really about kind of that personal history is taking into consideration Cassie and also her family lineage with the genetics, as opposed to somebody else that maybe had always really light periods. They don't have fibroids. Fibroids don't run in their family. Then you know that their uterine lining isn't so estrogen sensitive.
Yeah. Now let's talk about we're going to do this as a separate episode, but you just mentioned uterine lining and thickened lining and hyperplasia and all that stuff. So let's talk about a patient that I just talked to recently. 61, been on hormone replacement because of bone density issues. She's like 100 pounds, soaking wet, maybe 97 pounds, or she fluctuates between the upper 90s and the low hundreds. We did some blood work earlier in the year, and her estradiol was 138. Okay, so kind of in that what we consider to be sort of the danger zone for hormone replacement.
Because she's on static dosing, not rhythmic dosing.
Yeah, she's on static dosing. She's on biased. So biased, she's getting some estradiol, like this question, and she's getting some estriol, 80-20, like very common. So we decided, because of the blood test, which I didn't think that her dose was commensurate with her estrogen level, meaning that her dose wasn't that bad for it to be as high as it was. I said, you know what, if you're going to go into your gynecologist for an annual or something like that, you might want to ask for a transvaginal ultrasound.
You're so gentle about it.
What do you mean?
Saying you might want to ask. I'd
Well,
say, okay,
well, I'm just,
it's time to get a transvaginal ultrasound.
No, it was high. It needed to be done. She told me though, her sister prompted her sister. They're not twins, but they're very similar body type. Her sister is doing some kind of a program, and she lives in Italy. She's American, but I think she's married to an Italian guy. Over there, they actually require women that are on hormone replacement to do a transvaginal ultrasound every year.
That's so smart.
Right? It's very smart. I think they should institute that here in this country. Get rid of the PAP after the age of 50 or 55, or potentially
Depending on circumstances.
Depending on circumstances, or alternate, do one every other year or something like that. But every woman that's on HRT should be getting a transvaginal ultrasound. So long story short, estradiol was 138. A little bit, because usually with biased static dosing, you never see it that high. I mean, you typically don't. So it caught my attention, said, go and get a transvaginal ultrasound, and her endometrial lining was 10.3. Okay, so anything under 6 is normal. Anything above that is now what you're saying is endometrial hyperplasia. So now she has to go have a D&C, like you said.
Which is a good idea. I mean, you can alter the hormones, of course, raise up that progesterone, try to thin that lining a little bit, maybe try to get her to get a bleed. But at 10.5, that's
10.3.
10.3. That's still a lot. It is a good idea for her to get a D&C. D&Cs are really easy. I mean, it's a procedure. You got to get it done, but it's relatively innocuous and invasive. Is just get that lining down to the very thinnest and then go from there.
Now she wants to try a progesterone challenge, trying to shut off the lining. She's 61, already taking progesterone. It's probably not going to work. I said we can try it, but the D&C is sort of your safe bet. Now the other option, this is where the follow-up testing is important. She could just stop the estrogen completely, and that lining might just regress on its own.
And it definitely could. Even sometimes stopping the hormones can cause like a quote unquote period or this kind of bleed. So that would happen. But then she'd have to get an ultrasound fairly soon to see did that 10.3 turn into 3.3 or is it like 8.5?
Right. That's why I told her, I says, we need a follow-up ultrasound in roughly about 3 months. And then let's say hypothetically you do a challenge, it works or it doesn't. I don't think it's going to work. She wants to try it. Stop the hormones for roughly 90 days, get another ultrasound. And if the lining is still thick enough, then the DNC can sort of be like the safety net on the back end of that. I told her at some point you're going to have to probably have that DNC. At least you got to have at least one more follow-up ultrasound to see if it's regressed, and if it's still above that, even above or close to that 6 millimeters, the DNC is still necessary. So
Now, a thickened lining isn't it happens. And that's what happens with hormone therapy. Is some women, their lining is just so sensitive that they get that thickened lining, and it's just a thickened lining. But in a lot of, whenever you see that thickened lining, it is something to think about. So if they did a DNC, they would take some of that tissue and they would basically biopsy it, and then just to check that, make sure that there's no cancerous tissue or cancerous cells.
Now, her and I haven't been working together for that long, so endometrial cancer is going to take a while for that to sort of develop. You're not going to get endometrial cancer in 3 months.
I'm kind of surprised her gynecologist didn't suggest a biopsy or just said do a DNC and we'll use that tissue.
They wanted to skip the ultrasound and go right to the DNC. They wanted to sort of circumvent the process a little bit. Now, granted, the DNC is sort of the right decision to make. Like we talked about, she could maybe stop them for 3 months, the estrogen, and see if it regresses on its own. But that you still need that follow-up ultrasound to know for sure. And I don't, from 10.3 to under 6, I'm not sure if it might regress a little bit, but I'm not sure it's going to regress enough.
No.
And she was on 200 milligrams of progesterone, so she's clearly very sensitive to the estrogen, and she wasn't on a very high dose to begin with. So small, petite, very,
body size.
Yeah. So, not necessarily her body is not used to lots of estrogen based on her body type. So clearly, when she started the hormones originally, in the first little bit, she got some spotting right off the bat. So it already gave us a clue that she was a little sensitive. And then here it's been now probably a year, maybe a year and a half post-bleeding. We raised up her progesterone, and now there's been nothing ever since. But now the ultrasound, it's 10.3. Yeah. In some ways, that's worst case scenario, because you'd want the bleeding now when her lining is at 10.3, not early on and have no bleeding, because now you're sort of flying blind unless you get the ultrasound done.
Absolutely, yes.
Yeah. So the ultrasound is sort of a very, for those women out there, you're concerned, you want to make sure, have that ultrasound every year, just to make sure that lining is below, 6 millimeters, especially if you're using the patch, right? Because her estradiol number was 138 using bias.
Yeah, that's too high. You don't want it to go over 100 if you're on that static dosing. But can I ask? So I know she was doing this for bone density. How's her bone density?
Her and her sister have a little competition. So they both doing relatively the same protocol. And both are, they lift weights, they work out. She's got her little weight set in her house, and, pumping iron, got her little weighted vest, goes for walks. So she's doing her part lifestyle-wise, has a good diet, not a lot of processed food, adequate protein, and her bone density in basically, I think it was about a year and a half from one DEXA to the second, her bone density increased by 18%.
That's incredible. That's incredible. So that HRT is really good for the bones, for the brain, for the heart, but it is just making sure that you're keeping that uterine lining protected.
Something's going on over there.
I think one of our camera's batteries is kind of doing something funky.
It just popped out there. So maybe we'll wrap this one up.
Yeah, we better.
Nonetheless, vaginally.
It's blackout.
Yeah,
the lights are off. No, it's just our camera. Our camera, I think it had a lower battery, so it's probably dead. So we better wrap this up.
So I think we covered it. Estriol is a great option for Cassie, and get your transvaginal ultrasound. So
thanks for watching.
It's popping around. So take care. Bye bye.
Okay, bye.